But my hope is that this in the headlines has helped you to have some of these conversations with patients who are maybe formerly resistant to getting screened. Welcome to The PA is In, the show created by PAs for PAs, where codependency with your supervising physician is a thing of the past, optimal team practice is the future, and physician associate has taken the place of physician assistant as the professional title of choice. I'm Tracy Bingaman, and I'm obsessed with redefining what success as a PA looks like and what it feels like. Here you'll find the mindset shifts, systems, and processes I use to escape healthcare burnout and integrate my work into my life. Work-life balance is a myth, and an integrated life where you thrive professionally, not a balancing act, is the goal here. My mission is to help you to grow into a unicorn PA who loves their job, has abundant energy, time to spare, and work-optional financial freedom. The PA is in. Hey there, and welcome back to The PA is In. It's me, Tracy Bingaman, your clinician, career coach, surgery PA, and host of this show where we talk about all things work-life balance, boundaries, burnout, and the business of being a healthcare provider. Now, if you've been around for a little while, you know this. I don't usually do current events or even clinical recommendations. This isn't a news show. It's not going to help you prep for your boards, but sometimes, like right now, those current events line up with something that's clinically relevant and worth talking about. Today's topic, prostate cancer screening. So, as a former urology PA, seeing all of these clickbait headlines about former President Biden's prostate cancer diagnosis with questions about why he wasn't screened, it just made me sad. Those articles by reporters who aren't practicing medicine and don't maybe understand how PSA screening works aren't telling the whole story. Today, I'll do my best to unpack what we know about Joe Biden's prostate cancer diagnosis, given that it is sort of filtering through media, and remind you of the USPSTF and AUA screening guidelines and what those things tell us about prostate cancer screening and what should we be doing as a part of taking care of our patients who need prostate cancer screening. Have you ever opened a CT, MRI, or X-ray and felt a wave of self-doubt? You're not alone. Whether you're a new grad or stepping into a new specialty, reading imaging can be one of the most intimidating parts of clinical practice. That's where Guardian Light CME comes in. This interactive, case-based tool helps you to sharpen your imaging skills and earn CME while you do it. Start now at zaronlabs.com/guardianlight and use the code Tracy10 for 10% off. You'll review real-world cases with clinical context, scroll through the actual imaging just like when you review imaging at work, and here's the best part, test your eye by toggling key findings on and off to see if you can catch them on your own first. You'll find real imaging impressions, clear teaching points, one-click CME certificates, and new cases sent directly to your inbox each and every week. You get to see it, know it, and catch it before it matters most in real life. Are you ready to gain clinical confidence and read images with ease? Head to zaronlabs.com/guardianlight. That's ZAURON labs.com/guardianlight, LITE, with the code Tracy10 for your discount. So here's what sparked today's episode. Former President Joe Biden was recently diagnosed with prostate cancer. The White House confirmed that he had an aggressive form, which has already spread to his bones. He's 82 years old and has begun treatment with hormone deprivation therapy. And while the tone from his team is quoted as optimistic, and he has said, "My bones are strong and I'm feeling good," this diagnosis naturally brings attention to prostate cancer and more specifically, screening. There were lots of articles questioning why Biden wasn't screened, given that he was the past president of the United States and he was the active president of the United States in the years directly leading up to his diagnosis. A person who, one would think, has the most thorough access to screening and healthcare, potentially in the entire country. Now, we're not diving into politics here at all, but we are going to talk about what this means from a healthcare and prevention standpoint because of this diagnosis at his age. It's really not newsworthy. Yes, I know it's cancer in a former president, but most men die with prostate cancer. And almost all men will get prostate cancer or a malignancy in their prostate if they live long enough. Finding accurate information on this diagnosis has presented a challenge. So here's what we know. In May of 2025, at the age of 82, former President Joe Biden was diagnosed with what sounds like stage 4 prostate cancer with a reported Gleason score of 9. There are reports of metastasized cancer with lytic lesions in his bone. Biden was quoted as saying he feels like his bones are strong and he's doing and feeling well, and his treatment plan includes hormone deprivation. A little caveat here. I have not seen his medical records. I am not taking care of him. However, this is what I've gleaned from sort of the internet and news media and what has been released relative to this diagnosis at this time. Okay, before we dive deeper into screening guidelines, let's zoom out and do a quick review of prostate anatomy, function, and how we assess prostate cancer risk and severity. So first, let's talk about the prostate. The prostate is part of the male reproductive system. It's about the size of a walnut, which I find totally inaccurate based on all the patients I've seen with BPH. I would say that maybe it starts as the size of a walnut, can get much, much larger towards the size of a grapefruit over time. It's located just below the bladder and it wraps around the urethra, which is why it causes BPH and can cause retention when that benign prostatic hypertrophy occurs. Its job, the prostate makes the fluid that nourishes and transports sperm. So it's a key player in fertility and reproduction. As men age, the prostate can and typically does enlarge. And that's a whole separate topic in terms of BPH and prostatic hypertrophy. So let's shift to the PSA test. PSA stands for prostate-specific antigen, a protein made by both normal and cancerous cells of the prostate. We measure PSA levels in the blood, and that gives us clues about what's happening in the prostate. However, elevated PSA does not necessarily equal malignancy, which we're going to talk about a little more. So typically, a PSA level under 4 is considered normal, but like so much in medicine, it's not that black and white. So PSA can go up for a variety of reasons concerning, for cancer versus non-malignant sources like inflammation. Things that can elevate the PSA include BPH. So just enlargement of the prostate, common with aging, can have that PSA rise slowly over time. Prostatitis, inflammation or infection of the prostate, recent ejaculation, trauma like riding a bike or anything that puts pressure on the perineum simply causes an inflammation or a release of that PSA. Even a digital rectal exam right before the blood draw can cause a little bump of that PSA. So while a rising or an increased PSA can be a red flag, it's not diagnosed by itself, and it certainly doesn't necessarily mean malignancy. That's why PSA testing should always be interpreted in context. Look at the patient's age, the rate of the rise, are they having any symptoms? And, is this something that they've been normal all this time and then it's spiked? So in urology, we would say, oh, this is concerning, but I'm not concerned enough to biopsy you based on that. Let's repeat it in 6 weeks. Let's see if things have calmed down and give them some specific parameters for like no ejaculation before blood draws. Are you a long-term, bike rider? Talking about some of those lifestyle things to see if there's anything that explains that rise. So a quick word on BPH. Since I mentioned it, BPH or benign prostatic hypertrophy is non-cancerous. It's just the prostate being enlarged. It can cause dribbling, a weak urine stream, retention, hesitancy, or difficulty starting that urine stream, frequent urination, especially at night. There's a lot of crossover between nocturia, sleep apnea, and BPH in this population. And this feeling that patients are not emptying their bladder completely, like they're incompletely voiding, like they just went and they feel like they have to go again with a sense of sort of frequency or even some urgency when they're not emptying their bladder because there's this outflow obstruction from the prostate. So BPH totally separate from cancer, but it can complicate PSA levels and symptoms because simply having an enlarged prostate can mean that your PSA is going to go up. So Gleason scores, what they mean. So Gleason scores are how prostate cancers are graded on pathology. So the Gleason score is how pathologists grade the aggressiveness of a prostate cancer based on how abnormal the specific tissue sampled looks under the microscope. The scores range from 6 to 10. 6 is typically low grade, less aggressive, potentially a candidate for active surveillance. 7 is intermediate. 8, 9, and 10 are high grade, more aggressive, faster growing, and more likely to result in metastasis. So here's what we know from President Biden's team or former President Biden's team. They reported that his Gleason score was 9, meaning he's dealing with one of the more aggressive forms of prostate cancer. That combined with evidence of spread to the bones, places him in the high risk category, which requires a different treatment approach than a low-grade, slow-growing cancer, which might be a candidate for active surveillance, no surgery, no hormone deprivation therapy, depending on the patient and, sort of if they feel like they would be okay with that active surveillance. Are you feeling stuck, burned out, or craving a little more flexibility and financial freedom? You're not alone. So many clinicians feel trapped in the grind, overworked, underpaid, and unsure how to pivot. But here's the truth. Your skills are valuable beyond the clinic. That's why I created the 48 Side Gig Ideas for Healthcare Providers Guide, a free PDF packed with practical, creative, and immediately cash-generating ideas that you can start right now. From telehealth to medical writing and patient advocacy to app development, and even a little note on podcasting, these things aren't fluff. These are real, proven opportunities that other providers are already doing. You don't have to figure it out alone. This guide will help you explore new passions, learn how to make extra money, and make the first step towards multiple income streams and building the life and career you actually want. Download your free copy today at tracybingaman.com/gig or click the link in the show notes and start creating financial freedom and cash flow flexibility on your own terms. Because you, my friend, are more than just your clinical job, and taking the first step to generating alternative revenue streams is waiting for you inside the Side Gig Guide. Find it now in the show notes. Let's review the current guidelines from the USPSTF, or the U.S. Preventative Services Task Force, for prostate cancer screening. For men aged 55 to 69, the recommendation is screening with PSA should be an individualized decision made after discussing the risks and benefits with your patient. It's not a blanket yes or no. This is shared decision-making at its finest. This is the age group, 55 to 69, where you have a conversation with your patient about PSA. I would say in practice, most people are screening these patients Q1 to 2 years. For men who are otherwise at low or, sort of typical or standard risk for prostate cancer. For men age 70 and older, the USPSTF recommends against routine PSA-based screening. Specifically, it says do not screen for prostate cancer in these patients over the age of 70. Why? Because of the potential harms: false positives, overdiagnosis, overtreatment, unnecessary biopsies. These things may outweigh the benefits at that age. Now, if we look at the AUA, the American Urologic Society, they also recommend shared decision-making between the patient and the clinician for the decision to screen or not to screen. They recommend PSA as the first-line screening test. And if you have an elevated PSA, repeat the PSA again before secondary labs, imaging, or biopsy. Do not skip that step. If it is elevated, give it a chance to come down before you go doing further imaging, further biopsy, doing some of those interventions, which may prove to be unnecessary if that PSA comes back down on recheck. They recommend a baseline PSA between the ages of 45 and 50, and then a PSA every 2 to 4 years for patients aged 50 to 69. Clinicians can personalize rescreening individuals or decide on discontinuing screening based on patient preference, age, PSA level, prostate cancer risk, life expectancy, and general health. These recommendations aim to personalize screening strategies, ensure that patients receive tailored care to their specific risk profiles. So technically, former President Biden at 82 falls into the group where screening isn't recommended. But here's where things get murky. So we don't have access to his records. I mean, you might, but I don't. So if his PSA was elevated in the past, maybe they were trending it. Maybe they were following it because before age 70 it bumped, and they were just following it to see if it was going to steeply rise. Also, as the president of the United States, I suspect they're performing lots of tests and screenings that are outside the bounds of these recommendations. I bet he's probably having stress tests and cognitive tests and all of these different things that maybe aren't standard for the average 82-year-old who are walking into a primary care provider's office for their routine physical. So we know the data, but these guidelines are just that. guidelines. They don't replace clinical judgment, and they don't know your patient like you do. That's why shared decision-making is so critical. This diagnosis, whether you agree with the fact that he was screened or know what was going on or not, is a reminder that while screening might not be recommended for all men over 70, it doesn't mean that no one over 70 should ever have a PSA, ever. Deciding to screen patients is about individual risk, life expectancy, and what matters most to that patient. You may have some patients that are begging you to get a PSA because they won't be able to sleep at night without it. Maybe they have a family history, and even though they're over 70, they still would want to know in terms of letting other people in their family know of their risk, etc. So here's your clinical takeaway today. Know the USPSTF and the AUA guidelines if you are seeing these patients and having these conversations about whether or not to screen for prostate cancer. Have those nuanced personal conversations with your patients and really engage in that shared decision-making, see where their head is at, and see what's going to make them feel comfortable and like they've been effectively screened. And remember that big headlines can offer important reminders about prevention and risk, but ultimately individualized care is what matters here. But that things like this clickbait and these headlines like aggressive disease and advanced spread of disease and bone spread might not reflect the true medical picture. But my hope is that this in the headlines has helped you to have some of these conversations with patients who are maybe formerly resistant to getting screened. I'd love to hear from you. This was a little outside my comfort zone. I felt like I had to do some research on the guidelines, not just making recommendations about handling stress and, going through your normal, clinical practice of medicines. Do you want more episodes like this? Do you want me to cover articles and current events and guideline updates? Let me know by DM on LinkedIn or leave me a review. You can send me an email to info@tracybingaman.com. I want this show to serve you in your practice, whether that's coaching your career or sharpening your clinical edge. Until next time, stay persistent and remember, you are not alone in this work. That's all for today. This PA is out. Congratulations, you've just joined an awesome club. By listening to a full episode of The PA is In, you are officially on the Unicorn PA team. Welcome aboard. What most team members do is they subscribe to the podcast because that allows them to automatically get the latest episode of the show. The life of your dreams exists on the other side of taking action. Keep making small shifts and keep getting better. Your life will improve, your career will soar, and you will have the confidence you need to create your own success. I will see you in the next episode. This PA is out.